Good afternoon, ladies and gentlemen, to the third session of the Lifebulb Columbia Patient Information Program. This session is entitled Preparation After Dialysis, Starting the Transplant Process. What it essentially means is that we're going to discuss the initial preparation to get on the transplant list or to recruit donors for your transplantation. We will start by introducing the panel and the moderators. I will start with myself. I'm a surgeon. I'm a professor of surgery and a director emeritus and founder of the transplant program at Columbia. Next is Dr. Karen Hechenberger, who is the CEO of Lifebulb, and both a physician and a PhD, so that she's very qualified and organ recipient. Dr. Lloyd Ratner is the director of transplantation and of kidneys and pancreas at Columbia University. He's professor of surgery at that institution. Mr. Brian Runge is the chief coordinator for donors at this time, has been chief coordinator for recipients in the past at Columbia University Transplant Program. Dr. Geoffrey Dube is assistant professor of medicine and one of our senior nephrologist on the transplant service. And Gretchen Boyd is the chief coordinator for the transplant, renal and pancreas transplant programs at Columbia. So we will start initially with the questions that were sent to us. And I think Dr. Hechenberger will start.
So thank you. Thank you so much, Professor Hardy, and thank you to the co-moderators as well as our panel members. We're really excited about this session, and I know that our listeners are looking forward to both asking questions as well as listening to your responses. It's really a privilege for us, for Lifebulb, to be working with Columbia on this effort focused on patient education. And we also thank Veloxis for the sponsorship so that we can make this a reality. I want to start by saying Dr. Hardy introduced me as the CEO of Lifebulb, and that is the function that I fill. But 13 years ago, I was in this position waiting for a transplant, and I was very much in this role of exploring what to do when you're at end stage renal disease, in my case. And I was fortunate enough to have a direct connection with, be put into a direct connection with Dr. Ratner. And that's how my journey kind of embarked upon after that. So I do know the questions that patients are asking, and the families as well around the patient, because I do remember a lot of conversations with my family at that point in time, and what to do next and where to go. In my case, I was not on dialysis; it was preemptive, but the same questions kind of are there. So, the first question is, how do you choose your center? How do you evaluate the teams that are operating at those centers? And how do you even make that first connection? In my case, again, I was very lucky to have a person who knew Dr. Ratner and put me in touch with him, but that's not always the case. So I'm going to ask Dr. Ratner, how does it normally happen, or is my case a case that is normal?
Well, it's all over the map. People know people. People have been getting their care at a particular center already. They get referred by their doctor or their dialysis program or whatever. But I would say, sort of the first criteria for getting a transplant is being able to show up. So, you know, you have to be able to get to your transplant center, not just for the transplant, but also for the extensive follow-up care that's necessary afterwards. So if a center is too far away, or you have difficulty getting there, there's no public, you can't, you know, if you don't have your own transportation, if you can't get public transportation or whatever, that's sort of the first criteria. Now, fortunately, here in New York, we're blessed with a lot of really good transplant centers. Now, obviously, we have a bias that we think we're the best, but you know, the reality is that most transplant centers in the United States are pretty good and have excellent results. And if you look at the quality of outcomes with transplant across the country, they're all pretty close. Now, what differs quite a bit is how many people actually get transplanted, how long they have to wait, and the percentage of transplants that come from living donors vary quite a bit. So first is, you know, if you have a living donor, I would go to a place that does a lot of live donor transplants. You want to make sure your donor gets taken care of as well. Second is, if, you know, what percentage of people actually get transplanted and how long do they have to wait? And then finally, you know, do you get along with the people? Do you like them? Are they, you know, do you have are you able to have a rapport with them? Do they answer your questions? Or do they treat you sort of just as another, you know, sort of a generic patient? So I think those are some of the things that you need to look for when assessing a transplant program. So I'll stop there and see if any of my colleagues have any additional comments on that question.
Dr. Dube?
Yeah, I would echo what Dr. Ratner said. I mean, you know, you show up at the, you know, for your evaluation and start to meet people, and you know, transplant is like our transplant patients are part of an extended family, and so you kind of meet all the members of the family when you come in for the evaluation. And you know, I think you want to find a place where you feel comfortable, because you're going to be spending a lot of time there. You'll get to know your pre-transplant team very well as they shepherd you through the process, through the waitlist process, and you're going to know your post-transplant team very well as well. You're going to be spending a lot of time with them, and so having that comfort level and feeling like, you know, they're listening to you, your questions are getting answered, I think plays a large role in terms of deciding which center is best for you.
Maybe just to add to that, can I just add to that? Because again, I think that was a really important point, is this visit that is the evaluation is a day-long visit where each member of the team evaluates you, talks to you, spends time, and you really get a feeling for the overall team. And it's not just the surgeon or the nephrologist, or it's the coordinator, the social worker, the mental health person, the nurse. And I think everyone is equally important in that moment. And I think that is reflected by the process. Everyone is given a pretty extensive time, but you also have to be prepared to spend that day at the center. That's a long time to talk about yourself.
Patiently. Gretchen, perhaps you can comment on this whole day examination, because this is really the time when the patient gets a feel, so to speak, for the transplant centers. So the initial question is which center to pick, and Dr. Ratner commented about the distance and the quality. The quality is more or less similar in most places. The size of the transplant program, I think, may be important in terms of experience, but it may also be a demerit because it's a matter of mass production versus boutique type service. But nevertheless, I think that the larger units have more experience and a bigger staff. So Gretchen, perhaps you can comment on the process itself and how the patient can develop a feel for the various parts of the program, for the various interaction among the group between the surgeon, the nephrologist, the coordinators, the finance people, and social workers, and so on, nurses.
Sure. Thanks, Dr. Hardy. So let's talk about the process of how to get on the list, right? Or how to get a transplant. So it starts with referral. Dr. Ratner mentioned, you get referred to a center. People with kidney disease can either self-refer, meaning you can reach out to a transplant center yourself. You don't have to have a physician do it for you. So some patients just contact the transplant center directly, either via phone or we at our center have an online questionnaire that a patient would fill out, or your physician can do it for you, or sometimes the social worker at the dialysis center. So
But let me interrupt you for 1 second,
Sure.
because that's a very important point. Should I, as a patient, pick the center myself, and how do I choose it in terms of the data collection? Or should I just follow my nephrologist recommendation, which frequently may be just because he happens to be on the staff or has graduated from the program where he recommends you, not on the basis of actually data.
Right. So it's, it depends on your close relationship with your nephrologist, how well they know you. Sometimes the nephrologist is someone that you just see at dialysis and you don't have a relationship with them that you can potentially trust, who they're referring you to. So we always encourage patients to go to the SRTR website. The data for all transplant centers and our outcomes are readily available on the SRTR website. It's public data. You can go on and see, what is the outcomes of these different transplant centers to judge for yourself, where am I most likely to get, the care that I'm looking for. But like Dr. Ratner and Dr. Dube said, it's about logistics. How easy is it to get there? We might want to travel several hours to the transplant center for appointments. Pre-transplant, certainly not post-transplant, because we're seeing you, very frequently after post-transplant. So logistically, how easy is it to get there? And then just, reaching out to the transplant center and getting a feel for how responsive are they? How helpful is the person on the phone? Do they make you feel like your questions are going to be answered, in a timely fashion, and giving you all the information that you really need to make an informed decision about transplant? So it's kind of, there's a lot of information out there, to help you make your decision as far as where to go for the transplant.
Let me add 2 additional points. The first point is that particularly if you have some unusual or difficult problems, not every transplant center will be willing or up to tackling that. So, if someone gets turned down by one transplant center, it doesn't mean that they would necessarily be turned down or discouraged by another transplant center. The second point is that patients are allowed to be on the list at multiple transplant centers, and particularly if they're spaced far enough apart and gives you access to a different organ, for deceased donor transplants, a different organ donor pool, it is frequently in the patient's best interest to be multiply listed and be seen at multiple transplant centers. And the same is true, centers will have different criteria for who could donate a kidney or not. So just because someone is turned down by one center as a donor doesn't mean they would necessarily be turned down by all centers as a donor. So those are kind of things where it's worth looking into, particularly, like I said, if you have a difficult or unusual problem.
Dr. Dube, could you comment on how you recommend in terms of the choice of a donor, whether the patient should have a living donor or a deceased donor, and can they actually be on the list for a deceased donor while they try to locate a living donor?
So in general, the outcomes with kidney transplant from living donor are significantly better than the outcomes with deceased donors. You know, obviously the kidney is coming from someone who is both alive and healthy enough to donate a kidney. And so what we see is those kidneys work better from the start. They have fewer short-term complications. The initial hospital stay is shorter. They have fewer long-term complications. They work better over the long term. On average, they last about twice as long as kidneys from deceased donors. So whenever possible, a kidney from a living donor should be considered the optimal treatment for kidney failure.
So can I have a kidney before I go on dialysis, Dr. Dube?
Absolutely. And in fact, that's probably preferable. You know, so most people will get referred, or ideally will be referred to transplant when their kidney function is 20% or so of normal, what's called the estimated GFR. And at that point, you can get put on the waiting list and start gaining wait time for a deceased donor kidney transplant. However, because of the long waiting times for deceased donor kidneys, it's not always possible to get what we call a preemptive kidney transplant from a deceased donor, meaning that you never need to see a dialysis unit before you get your transplant. There's obviously no waiting list if your family member or your friend wants to donate their kidney to you. And so ideally, you identify a living donor who is able to donate to you either directly or through a paired kidney exchange if there's some immunologic reason why they wouldn't be able to donate to you directly. And then you never have to set foot in a dialysis unit. You get that living donor kidney transplant, and you get the benefits of the living donor transplant. If you show up initially and you haven't identified a living donor, we can put you on the waiting list. You can start gaining waiting time for a deceased donor kidney. And at any point in time, if somebody comes forward and wants to donate to you, then by all means, you bring them in, get them evaluated, and we can still get you that living donor transplant.
It actually addresses one of the questions that we have received already. Thank you for the question. The question was really, when do you start looking for a living donor? At what point in time do you start searching? So I think you were talking about that as when you reach a certain level of GFR. I know that our patient is grateful for that response. You know, as you go through this process, and we heard about that long day, and what do you recommend the patients? This is real practical. So I don't know, maybe Brian or Gretchen, you know, would be even better at addressing this. What as a patient do you bring? You know, what do you bring to that day? Should you bring another person, a listener, a family member? Should you bring food? What do you think are some practical advice for the day of evaluation?
Yeah, I can chime in on that. You know, the day is, and this was, you know, your time was before COVID when you came. It was an all-day event. You know, you try and get as much in as possible because it's difficult to come into the city and find parking. So you try and do as much in one day for recipients and even donors. You know, what is commonly not really realized or thought of on those evals is what you touched on is, should I bring somebody? And everyone, whether it's a living donor or a recipient, especially recipients, should bring their support because they're meeting with social workers and possibly therapists or psychiatrists for an evaluation. They may want to get to know the support person. Is this person going to be able to have support after they get a transplant, because they're coming back a lot, taking meds, and a lot of information is thrown at these individuals all in one day. And we, of course, don't expect them to remember it all. And that's what the coordinators also are here for. But there's so much, it can be overwhelming. So to have a second person or even a third or just the whole family, if they want to come in, we recommend everyone is, you know, come in. I love when a group comes in. Bring food because a lot of transplant centers, you know, we don't necessarily provide that. So you're there. We give breaks so they'll be able to go over and maybe eat at the cafeteria at the hospital or have their own lunch if they bring it. Just bring themselves, you know, meaning be there with us because we're there teaching. We want everybody there to really try and get as much as they can because it is, again, overwhelming and there is a lot of info.
A question from
Lloyd.
the patients here saying, is this mostly done in one day? I think you answered that, but it's different now with COVID. I guess a lot of it is done per Zoom.
we get virtual visits now for certain, you know, New York, if they're New York State residents, anybody, Dr. Ratner, Dr. Hardy, Dr. Dube, all of our doctors are licensed in New York, so they can do a bunch of virtual visits just like this meeting, you know, and do an evaluation. If they're in certain other states, New Jersey, a lot of our nephrologists have license there to do virtual. So the visits can be virtual with the nurses, social work, some of the nephrologists and surgeons. But then there is the ultimate, now come in and you have to have your physical, you know, check done by a surgeon or a nephrologist, and then do the other tests that we require maybe at Columbia, like for living donors, a CT scan or chest X-ray or EKG stress test.
So, Mrs. Boyd, in terms of the memory of the patients, as was mentioned by Brian, do we have material like videos or webinars on our review of the pre-transplant workup? Do we have any discs that we can give the patients, or can they get any information on the website?
Sure, we have an education video for patients kind of learning about the process of transplant, the referral, what is the evaluation like, what does it entail, how do I get on the wait list? So basic information about where to start. We do have a video. It's on our website. We can also send out the link to the video, you know, if asked, if requested. So we have that, but then there's just constant education throughout the whole evaluation process. Education by the coordinator, education by the physician, the social worker, everyone that you meet kind of provides some education and answers questions about what to expect during the evaluation and what to expect after transplant. So the education is continuous. It goes through all throughout the evaluation process. And then after kind of once the evaluation is completed and all the testing and all the meetings with all the team members are done, then we as a transplant center meet as a team to discuss candidacy, which is basically, you know, is transplant going to be a good option for this patient, safe and a good option for the patient, and improve their quality of life. And if we're ready to place someone on the waiting list, we do have at our center an additional education class about, you know, now you're done with the evaluation, you're about to go on the list. What does that mean? What is the list? And we go through a lot more detail about what it means to be on the list. What are our responsibilities? What are the patient's responsibilities? What happens when you get a phone call for an organ offer? You know, what do you need to do? How quickly do you need to get to the center? So we provide that education class just before going on the waiting list, so you know what to expect going on the waiting list.
Could any of you comment on what does it mean to get on the waiting list? What is a waiting list?
So I want to piggyback off of what Gretchen said, and actually even like going further back to choosing your transplant center. You can move transplant centers. That is your right as a patient. And again, to Dr. Ratner's point, you should go where you feel comfortable. Your coordinator, and I tell all my patients this, I did it when I took care of recipients, I do it when I take care of donors now. We are your best friends with transplant. There's so much information you're not going to remember. Call your coordinator. Your coordinator will tell you exactly where you're at in the process, what you need to do. Are you on a list? And in terms of Hardy's question, Dr. Hardy's question is, what is being on the waiting list? It is a loose term to say, oh, I'm on the waiting list, because there's different types of listing. The waiting list is the United Network for Organ Sharing. That's the UNOS nationally run kidney transplant or even heart or lung, looking at those organs, registry for deceased donor. We do list living donors on that list, but just to report transplants and do donor follow-up. But being on the list as a recipient means getting on the kidney transplant waiting list to start either as a status 7 to start gaining waiting time, or as a status 1. That means you're active, cleared, been worked up at said transplant center, and you are now eligible to start receiving kidney organ offers. And there's different statuses, so it's like status 7 and 1. There's different ones in between, but those are more emergent listing statuses, kind of like recipient, you've exhausted all status 5 is you've exhausted all dialysis options for them and you cannot dialyze them. You basically list them as a 5 if you've gotten approval from all other transplant centers around, and they jump to that list because they cannot get dialysis and the end is going to be possibly near for said patient. So there's different listings, but typically we use status 7, meaning you're just on the list, but you're on hold. Maybe you're doing your workup or you got sick and you had to be put on hold, and status 1 active. And if you're on dialysis, when you get listed, you get now your waiting time from when you started dialysis. So if you've been on dialysis for 20 years, you'll get 20 years of waiting time in your pocket. And that's a lot of waiting time.
Thank you. We have a question that relates to that. How do you get, or do you ever get kicked off the list?
Dr. Ratner perhaps can answer.
Yes, yeah.
Yeah, well, we don't like to kick people off, but you can get kicked off the list. So first question is that we ask is, as time goes on, do the risks of transplant outweigh the benefits? So obviously we don't want to transplant someone and make them worse, but their illness could progress. They could develop new illnesses that may make it so that they're that the benefits aren't there anymore, or that the risks exceed the benefits. And then, we have some patients who, are non-adherent or non-compliant and don't do what's asked of them to continue to enable them to be a candidate or to be a good candidate for transplantation. Or once in a while, we get patients who are abusive to our staff. And certainly, we think that's inappropriate. We don't take throwing anyone off the list lightly, and there are all kinds of procedures that have to be taken. But, if the benefits no longer outweigh the risks, if people prove that they don't do what's asked of them, where again, that becomes, if someone's not doing what they're supposed to do to get a transplant, will they do what they're supposed to do to take care of a transplant afterwards? And will they wind up wasting an organ because they don't take their medications or they don't come for follow-up visits?
Sorry, a question there, Dr. Ratner. Is that the same for a living donor? Because if it's your parent or your sibling and it's an organ that is being given willingly by that person versus being on the list for a diseased organ, how do you evaluate the adherence and the other diseases?
Well, sure, it's a similar equation, but it's a little bit different. Obviously, we don't want to put anyone through surgery and put them at risk if their gift, their donation is going to be for naught or is going to be not well taken care of. I always tell sort of an old joke, when men receive a organ from their wife, it's the brave man who doesn't take his anti-rejection medicine. And it probably goes both ways as well, although, but no, we want people to do well and be successful and live happily ever after. And, and if they're not going to prove that they are willing to take care of themselves or can take care of themselves, or again, if the risks outweigh the benefits, even if they have a living donor, we wouldn't proceed with transplant.
So if you have a certain age limit for doing surgical procedure on a person from the list perspective, but that person has a child that says, even though my parent is older or grandparent is older, I want to give this organ, you would do it, but not if the risk was too high for that person to survive.
Correct. And we don't have an age limit per se, but we do know that the older someone is, the more likely they are to have other medical problems, which then shifts that risk benefit ratio. So for instance, if someone's 80 years old and their anticipated waiting time is 5, 6, 7 years for a kidney, we say, okay, if they're going to get a deceased donor, what are they going to be like when they're 85 years old? Are they likely, well, are they likely to benefit from a transplant at that point? Whereas if they have a living donor at that age, then we could, one of the great advantages of having a living donor is that it's elective surgery. The recipient could be optimized. Everything could be optimized because it's scheduled, it's planned, it's elective, as opposed to a deceased donor transplant where, when we get the kidney, that's, we don't have a lot of control over that.
Usually in the middle of the night. Dr. Dube, could you comment briefly about the kind of diseases that would make you hesitate to put the patient on the transplant list or take the patient off the transplant list? For example, the obvious one is cancer. So if a patient develops cancer, they come off the list and they have to wait a certain amount of time before they go back on the list. What about other things? What about diseases of systemic diseases or heart disease or lung disease and so on?
Right. So, with cancer, obviously it depends on the type of cancer in terms of how long you might need to wait. With a very early, mild basal cell skin cancer, which is the most common type, oftentimes doesn't actually preclude someone from getting a transplant. With more advanced cancers, oftentimes, that may rule somebody out as a candidate for heart
What about
disease.
kidney cancers?
It depends on, how big the kidney cancer was, when it was diagnosed, what kind of symptoms, if any, the patient was having. Some patients who've been on dialysis for many years can develop very small, tiny kidney cancers that get discovered when they get say a CAT scan performed for other reasons. And that may not, preclude them from getting a transplant, or there may not be that long a waiting time after the cancer has been effectively treated before they can be reactivated on the wait list. For something like heart disease, which is much more common among patients with kidney failure than in the general population, we make sure that those patients are seen by one of our cardiologists here, who spends basically all of her week dealing with patients with advanced kidney disease who are waiting for transplants. And we want to make sure that their heart is healthy enough to kind of undergo the surgery, get general anesthesia, survive the stress of the operation, and then continue working over the long term so that the patient can really reap the full benefits of having a kidney transplant. For other diseases, it'll depend on the type of disease. If someone had, say, emphysema, it might depend on how advanced the emphysema was. If it was bad enough where they were already requiring home oxygen, that might preclude them from getting a kidney transplant.
Why wouldn't they get it? They lived so far on oxygen. Why can't they go home on oxygen?
Well, there's, what depends on what the long-term prognosis is, but for patients who are already on requiring home oxygen, for example, that can be associated kind of with a worse long-term prognosis, where then the risk of undergoing transplant surgery, being mechanically ventilated, which might cause issues with the lung, those risks start to outweigh any potential benefits of getting a kidney transplant.
So we've talked about the age limit, there is none for the recipient. However, we got a question from our audience about age limit for the donor. Is there a donor age limit for a living kidney donation?
Dr. Ratner, do you want to tackle that one too?
Yeah, it's the
We got a comment from our audience as well that every difficult question is being turfed to Dr.
I'll take
Ratner.
it. You can correct me if I'm wrong.
Why don't you give it a try, Brian, and then I'll add my 2 cents.
Yeah. So again, we at NYP Columbia, we don't like to limit ourselves to age cutoffs, because there are those potential donors, a lot of transplant centers, living donor centers around the country that have maybe a 70-year-old cutoff. But there are some people that are over 70 and they're, in great shape. And so we like to take it on a case-by-case basis. I did see the question come through. It was I believe something like 85, and that would just be something that we would bring to our selection committee, which is a multidisciplinary meeting of all the nephrologists, surgeons, social work, psychiatrists on the donor team, and say, hey, we have this donor questionnaire from this donor, this age, this medical history or no medical history. would we consider moving forward? And there are times that we have, moved forward and been successful with some donors over the age of 70. But it also, you have to look at who they're donating to. If it's a younger person, maybe the kidney's not as good a functioning kidney because it's got some more miles on it, as Dr. Ratner loves to say. It's a used car, so it has more miles. It's not that it's not good, any good, because used cars are great, but maybe if it's a 30-year-old donor or recipient, they're going to need more transplants in their lifetime. So maybe we could potentially swap that donor with an older recipient who also then has a younger donor, and we do a cross swap.
It's important to consider the multiple transplants over a lifetime and figure out when is the best time to do the surgeries. I see that planning.
But Brian really emphasized an important point, is that the age of the kidney in the donor also has to be considered, where it goes. On the other hand, what I think he emphasized, and correct me if I'm wrong, if you have an 85-year-old man who regularly runs the marathon, then it's not quite the same in terms of the risk to their operation to actually perhaps use the kidney.
Yeah,
I think our audience has to remember that and realize that our major obligation is to the donor when it comes to the donor and the recipient. So in terms, and I don't know whether I'm
so
sure.
Sorry, Dr. Hardy, I thought that you have two teams working in parallel. One is taking care of the donor and one is taking care of the recipient. And both the recipient and the donor are equally valued, but by different teams. Maybe I am misunderstanding that.
No, we do have separate teams, and there is no conflict of interest. And that is, I'm glad you emphasized that.
But
Yeah, we have to
Hardy's-
watch out. Oh, sorry, Dr. Ratner, go ahead.
No, I was just going to say, that it's a little different taking someone who is healthy and undergoing surgery for no benefit to themselves than someone who's having surgery, to help cure a medical condition. So, in general, from the ethical standpoint, the donor's safety is paramount. And we could generally do the surgery and, leave the patient with one kidney so that they could live happily ever after if they've been through a very extensive evaluation and we've evaluated them for a whole host of things. But, in short, when we look at the donor and evaluate the donor, we want to make sure that, number one, that they'll be able to safely undergo surgery and anesthesia. Number two, that they'll be okay in the long term left with just one kidney. Number three, that they have two kidneys and that both of them are normal and that, we get a roadmap for the surgery by doing the CAT scan. Number four, that they could give an informed consent. They're not being coerced, that they have realistic expectations, and that they don't have any sort of secondary gains expected, and that they get that if things go wrong, either with themselves or the recipient, that they don't become pathologically depressed or anything like that. And that's why the donor evaluation is so extensive. Getting back to the question of age, like Brian said, we've used donors into their 70s. I think the oldest donor that I've operated on was 74. And I think to the best of my recollection, the oldest kidney donor reported in the literature was 83. But you have to be a really, really good 83 to donate your kidney, because sort of the old surgical adage is the 80-year-old who looks like they're 60 after general anesthesia looks like they're 100.
I think an important point on this topic is, as a recipient, don't try to screen out your own donors, right? Because I see in my experience, a lot of recipients will be like, oh, I have a donor, but they have high blood pressure, so they can't donate. or they're not compatible to me, or I've been told they're not compatible, so they can't donate. Let us as the transplant center figure out, on a case-by-case basis, if that donor is going to be a good donor for you. Don't try to screen out your own donors, because 20 years ago, we probably weren't accepting donors with high blood pressure, but things change, and now we potentially could consider someone who's well controlled on one medication. Things change over time, safety considerations change, data changes, outcomes, guide us in our practice. So just don't ever try to screen out your own donors, because you might have a missed opportunity. Just whenever you have a donor or someone who's interested, either have them reach out to the transplant center, or you as the recipient, just, touch base with your coordinator to find out, if that's going to be a suitable donor for you.
So that's a very important point. And Brian, can you expand a little bit on this in terms of, there was a question here that how early can you eliminate a donor when you see their list, their screening list first, and then what do you do?
So the donors go online and fill out a real brief, basic donor questionnaire. It takes a minute or two tops. And it's basically a brief demographic and medical a questionnaire. And that's the first point where a donor could essentially be ruled out. Say they have a high blood pressure and they're on 2 medications and it's not well controlled, or maybe they have active cancer. But again, you would, it's not, if you have breast cancer, you're ruled out now, but maybe in a couple of years, or depending on the recommendations, everything changes over time. We could reconsider you at that time. Perfect example is somebody that has a high body mass index. We would say, well, right now we can test you, but we can't move forward with you. But when you lose,
You mean they're very fat?
Yeah. Yes. Sorry. Body mass index. Yeah. But if they lose the weight, we would consider them. So they're not necessarily ruled out. They're just kind of deferred or put on hold. The other point in the process, after they do labs and come in and see the team for evaluation and do their CAT scan, stress test, if those things come back abnormal, and I tell all my donors, don't worry, don't panic until I tell you to panic. And that will literally be never. Because you can get abnormal results, but there's always something else you can do. You have an abnormal stress test. What do? We do maybe a more in-depth, different kind of stress test, or a cardiac cath, or send them to cardiology. You have maybe blood in their urine is a common example for donors. We send them then to the urologist. We try and exhaust all our possibilities before we ultimately say, look, it's not a good idea for you to donate. Donors, we tell them to keep it in mind that whatever we do is for their safety. This is a surgery they don't need to have. It's all elective. So we have to make sure this goes right. And even if we have to unfortunately rule out donors, it's for their good and their safety, because we don't want to take a kidney and then they need a transplant later in life.
But not only that, you must agree that actually you pick up occasionally in the workup, you pick up something that actually helps the donor to get better, whether with the heart or with a tumor.
That's a good point.
Or with anything else. So I think the workup for the donor is so exhaustive that it actually picks up little things and big things sometimes that are very helpful to the donor.
Yeah, and we explain that to them on eval. It's part of the donor consent is what's the risk of a donor evaluation. There's no real risk to them other than us finding something that they didn't even know they had, maybe cancer. That's been one, maybe a kidney problem, or maybe they didn't even know they had only one kidney. So those are things that healthy people don't undergo CT scans, might not even know until they come to us.
We are approaching the end here, but we have 2 more questions from the audience I think we should address. One is, what is the life expectancy of a donated kidney, a living donor and a deceased donor? And I know it's very hard to answer. It's an average. But kind of average.
Well, I think that one of the important things, I interfere now in terms of answering, but one of the things that needs to be emphasized, that it doesn't make too much difference whether you get a kidney from a living donor for a related living donor or an unrelated living donor, except under an unusual circumstance in brothers, in siblings, where there can be an identity, genetic identity without being identical twins between the siblings from the same parents. But as far as unrelated donors, living donors versus related living donors, there doesn't seem to be much difference in terms of long-term survivor. I would ask Dr. Dube and Dr. Ratner to comment on the present statistics in terms of the living donors versus deceased donors. There are a variety of deceased donors, which we will discuss at another session.
Yeah, so the kidneys from living donors will last roughly twice as long as kidneys from deceased donors on average. So the average kidney from a living donor will last probably somewhere between 15 and 20 years. It's an average, meaning half will stop working before 15 years for whatever reason, whether it's because of rejection, whether it's because of an infection, whether it's because the patient
of a car accident,
a car accident, etc. But half those kidneys will last beyond that average. Obviously, the younger and otherwise healthier you are at the time of transplant, the higher the likelihood that you'll be on the long side of the average. The average kidney from a deceased donor is probably more in the 6 to 10 year range, depending on the characteristics of the deceased donor. So kidneys from an older donor might not be expected to last as long as kidneys from a younger donor, or if the donor had some underlying medical conditions that might cause the kidneys maybe not to work quite as long, but about 6 to 10 years on average, which again,
it's hard to predict, isn't it?
Prediction, as I say, predictions are difficult, especially about the future. But we can get a rough sense, from the time of transplant, based on the quality of the organ, kind of roughly how long on average we would expect that kidney to last. And I think it's important to note that regardless of whether you get a kidney from a living donor or a deceased donor, or any of the different types of deceased donors, there is still a significant survival benefit compared with just staying on dialysis and never getting a transplant.
And let me make one point about the difference between the benefits of the living and deceased. Obviously, a huge benefit of the living donor is you don't have to wait on the waiting list. And so even though living donor kidneys are better starting at the same time point, the fact that you could get a kidney, 3, 4, 5, 6, 7 years earlier is a big difference.
There was one question that you can answer quickly, Lloyd. Is there an advantage to be on multiple lists?
Yes, it gives you access to a greater pool of organs, particularly if the centers are spaced far apart.
Yeah, that was the question, because I think Dr. Ratner already addressed the potential of having multiple centers, but the question was really, should they be spaced far away versus having them all in New York, for example?
Right. Well, the allocation has changed recently. So the allocation used to go from local to regional to national, where local was prioritized and then regional, then national, which was based on discrete geographic boundaries. So like, New York State versus New Jersey. But now it's the local allocation is defined as dependent on the hospital that the donor is in. For deceased donors, a 250-mile radius defines the new local. So it used to be that a donor that might have been in Hackensack, New Jersey, which is 8 miles from us, was more likely to go to Philadelphia or to Pittsburgh or to Washington, D.C. than it was to come 8 miles to Columbia University. But now that's all changed. So again, that 250-mile radius will also shift depending on where that transplant center is.
So you should go 250 miles away.
Well, not necessarily. You'll be drawing, if you go 125 miles away, you'll be drawing other hospitals that are 125 miles away.
Right.
Yeah, good. It's a lot of planning in this. I think one question that was a little different, and I'd like to maybe conclude with that because we've had a lot of questions on the donor characteristics and the timing and so on, was when you do the evaluation, do you also try to put patients in contact with other patients who have gone through the transplant journey? As a question for one of our patients, and personally, I'm quite interested in that. As well. Is there ever a connection with another person? I remember asking that question 13 years ago.
There absolutely is. So, we reach out to all of our recipients after they've been transplanted to see, would you be willing to kind of mentor or speak to, a recipient who has questions? And a lot of recipients do, and they are very interested. So our social workers maintain that list. So all a recipient needs to do is just reach out to their social worker or their coordinator, and we can certainly try to pair you up with someone who will be willing to kind of talk to you about the experience. And, because it's different from us telling you what it's like than someone who's actually been through it. So we absolutely have that opportunity, and patients find it to be very beneficial and helpful.
Fantastic. And we would, of course, like to recommend Transplant Life as well, which is a digital community for patients to connect
Fabulous.
with others who have gone through what they're about to go through.
Well, I think that we are finishing. I want to thank the panel and turn it over to Dr. Hagenberger to have the final word.
Well, thank you. I think this has been a great, very engaged panel and moderation and wonderful questions from our audience. So thank you so much. This is a complex process, but it's made, I think, clear from our key opinion leaders here. And it's nice to have representation from different parts of the team. It's clearly a team effort, and we've seen that from this discussion. Thank you very much, and we look forward to our next session that is happening, Dr. Hardy, in February 16th. February 16th, 2 days after Valentine's, and we look forward to having you all join.
And our audience should realize that one of the reasons we didn't answer some of your questions is because we will answer them in the future meetings. We try to restrict our answers to the topics that we outline. So some of the topics about the deceased donors and how they're managed and how we choose them will be discussed at the next few sessions. So thank you all, and we'll see you in February. Good night.
Thank you.
Have a good night.
Good night.
Right.